Welcome to Management of Acute Reactions to Contrast Media, RSNA 2019 Hands-On Workshop. My name is Carolyn Wong from the University of Washington. This year we will be doing a flipped classroom education format in which we are making this contrast lecture available before the course at RSNA. This will ensure you have adequate amount of time for the hands-on, high-fidelity simulation scenarios. This lecture will also be available after RSNA for you to view for further education. Our disclosure is that we received GE Education grant funding to help support the cost of the mannequin rental and technician support for the hands-on simulation portion of the course. Iodinated contrast media used to opacify organs and identify pathology can have allergic-like reactions similar to all medications. Fortunately, these are fairly uncommon and mortality is even less. With gadolinium, the reaction rates are even less common. However, this rarity of event results in uneven training experience, and the patient's survival really depends on the team's preparedness. With increased CT utilization, more reactions will occur. Radiology as a field is pretty poor at managing this. For example, Ninwana et al. Surveyed a bunch of radiology attendings, fellows, residents, and nurses, and 71% of them provided the incorrect dose and rate of intravenous epinephrine administration for anaphylaxis, and 48% gave the incorrect dose for intramuscular. When responding to a possible reaction, although your initial reaction might be to try to hide, there are two things that you should do: talk to the patient and take their pulse. Why is that? When you talk to the patient, you determine from themselves what their symptoms are. As you're talking to them, you can assess their level of consciousness, and you can also determine their degree of shortness of breath. Are they able to respond appropriately? Are they, like some patients, doc, I can't breathe, I don't know what's wrong with me? Or are they truly short of breath? I can't breathe. And are you sensing any voice changes or hoarseness, which would be a sign of laryngeal edema? And swelling in the upper airways is one of the ways that we could lose the patient because there's so much swelling that they're not able to intubate the patient, and then they have to do a cric, and by then the patient's been without oxygen for 10 to 15 minutes. Also, take their pulse, and this means just feel for it. If you can feel for it, it's palpable, then it has to be a systolic of 80 to 90 millimeters mercury. And is it going too fast or too slow? You don't have to sit there and actually count, but just determine subjectively, and this will lead you in your algorithm. Now let's start with the patient who's hypotensive. Now normally, when you're bleeding out, your body's job is to increase your heart rate because you want to increase blood flow to critical organs like your brain and your kidneys. So if you're bradycardic, this is not a normal response to hypotension. Instead, this is a vasovagal reaction where you've activated your parasympathetic system. So the treatment for a vasovagal reaction, or hypotension with bradycardia, is to elevate the legs approximately 60 degrees. You're trying to bring back as much fluid as you can into the central circulation. And give oxygen, preferably by face mask, 6 to 10 liters per minute, IV fluids, normal saline, wide open. And usually these non-medication approaches alone will work. Rarely, if the patient remains symptomatic, then you may need to escalate and give medication. And the medication of choice would be atropine. Now, atropine comes in this purple box, and it's 1 milligram in 10 milliliter. And you're going to only give it if you're bradycardic and you remain symptomatic, despite those non-medication treatments. And the recommended adult dose is 0.6 to 1.0 milligrams. Now let's switch gears to the hypoxic patient. This is a person who can't breathe. So they're anxious, they're agitated, they feel like they're suffocating. The key to this patient is the stethoscope exam. What are you hearing? Are you hearing expiratory wheezing, which is bronchospasm? Remember, this is constriction of the distal airways, so air can get in, but it can't get out. So you're going to hear or are you hearing inspiratory stridor, which would indicate laryngeal edema, which is a swelling of the soft tissues in the upper airway, and so the soft tissues are vibrating as the air is moving in and out, so you hear So whenever a patient is complaining of trouble breathing, oxygen is good for nearly all reactions. And so you want to make sure that you deliver oxygen in an effective method, so ideally via face mask. And remember, you have to have a high enough flow rate, 6 to 10 liters per minute, to clear the CO2 from the mask. Now, you'll recall recently that there was this Southwest airline when the oxygen came down, and they took these picture on social media. And the thing that airline safety people were so upset about is that clearly nobody pays attention because the instructions tell you to place the mask over your nose and mouth, and don't worry if the bag doesn't inflate because oxygen is coming in. Well, this is not true if you're in the hospital setting and you have one of these non-rebreather masks, which has a bag at the end. This bag needs to be partially inflated on both inspiration and expiration in order for the patient to adequately receive oxygen. So in acute bronchospasm, remember constriction of the distal airways, so air can get in but it can't get out. The recommended treatment is going to be a beta 2 agonist inhaler. And you're going to do 2 puffs and you can repeat 2 times. Now, the key to albuterol is that in all of your crash carts and all of your reaction kit boxes, these are new boxes. And these medications have not ever been given before. So you're going to first take it out of the box and you're going to want to shake it up to help the mixture mix up. And then you're going to want to squeeze into the air several times. Similar to when you buy a new lotion and you're pumping a few times and you can't get anything to come out, you just want to make sure that medication is actually being delivered. And then you're going to want to follow breathing instructions. So when the patient breathes in, breathes out, on a deep breath in, you puff, you have them hold their breath for as long as possible, breathe out, on this, then breathe in, breathe out, breathe in, puff, hold. That is 1 dose, 2 puffs. And then you can repeat 2 more times. Now, the key to albuterol is that it works nearly instantaneously, that people will feel that their chest tightness is improving and they can breathe better. If for some reason you have to repeat the dosing, then you want to start thinking about supplemental treatments such as epinephrine. Now, if the patient's having laryngeal edema, remember that's inspiratory stridor. The goals are oxygenation and reduce the edema of the upper airways. You're going to oxygenate by face mask 6 to 10 liters per minute and administer epinephrine, either 0.1 milligram of the 1 milligram in 10 milliliters intravenously or 0.3 milligrams of the 1 milligram in 1 milliliter intramuscularly, or use an autoinjector such as EpiPen. The concentration of epinephrine to administer intramuscularly is the 1 milligram in 1 milliliter, or the small glass vial, and you're going to be giving them 0.3 milliliters or 0.3 milligrams. And you can repeat, but the max total dose is always going to be 1 milligram. You're going to administer it into the lateral thigh. Because this is such a small volume, you're going to have to draw it up with a TB syringe. Epinephrine autoinjectors are also available in both an adult and pediatric dosing. So there's both the EpiPen, AviQ, and generic. The key for all of these is that you do not want to touch the loaded tip, which may be either orange or blue, because these tips are pressure sensitive, and if you touch them, you will auto-inject your thumb and cause thumb ischemia. Intravenous epinephrine is administered with the 1 milligram in 10 milliliter concentration, which is in this khaki-colored box found in all crash carts. So your starting dose is going to be 1 milliliter, or 0.1 milligram, and you're going to give it slowly over 2 to 5 minutes. So if you imagine epinephrine is like drinking 100 cups of coffee all at once, and how you feel when you drank too much coffee, the patient may feel jittery, they may have some chest pressure or chest tightness or palpitations, or they may feel like they're going to die, and all of that is normal as a side effect. However, the slower you give it, the less likely they're going to have those side effects. Whenever I'm thinking of giving epinephrine, the first question I ask is the person dead? And I don't mean this kind of dead, zombie movie dead. I mean this kind of dead, where the patient has no pulse, you're doing CPR, and you're about to defibrillate. If that's not the case, which hopefully is never the case in radiology, you do not want to give the full volume of epinephrine, whether that's that small glass vial or the bigger khaki box. So if the patient is not CPR dead, you're never going to give the full volume. Instead, if you're going to give intravenous epinephrine, you're going to give 1/10 the starting volume, which is 1 milliliter or 0.1 milligram of the 1 milligram in 10 milliliter. If you're going to give it intramuscularly, you're going to give 1/3 of the volume, which is 0.3 milliliters or 0.3 milligrams of the 1 milligram in 1 milliliter intramuscularly. So when I'm thinking about giving epinephrine in the muscles, I think to myself, well, there's a lot of muscle, there's fascia, there's soft tissue space, and just as a mental exercise, I realized the number is higher than number 1, and so it's 3, so it's 1/3 the volume. And so whether you're going to give IV or IM epinephrine is partially dependent also on what the patient's blood pressure is. If the patient is profoundly hypotensive, their extremities may not be perfused sufficiently for adequate absorption by intramuscular route. There's some pearls for intravenous epinephrine administration. First, you want to open the box from the bottom. If you try to open it from the top as you would a cereal box, the medications won't come out. And so you want to follow the instructions at the bottom that say press and pull to open. Then the 2 pieces fall out. Next, remove everything that's yellow. There should be 3 parts. Then slowly twist the glass vial onto the needle. If you try to force the glass vial onto the needle, there's a diaphragm that the needle needs to puncture through. And there's quite a lot of pressure that you have to use to do that. And so what would happen is that if you assembled it outside of the patient, this would squirt into the air. But if you were attached to the patient, you would accidentally overdose the patient. And so you want to always remember to assemble away from the patient. And don't give the full volume unless you're giving CPR. And you never want to give the 1 milligram in 1 milliliter or that small glass vial of epinephrine intravenously because that's super concentrated. And if you do that, you're going to cause some sort of adverse event such as a heart attack or a stroke. Now remember, you're only giving 1 cc of the 1 milligram in 10 milliliters. So this is a very small volume. And your catheter has about 0.5 cc's of dead space. So if all you do is give the medication, half of it's still in the tubing, and so you've underdosed the patient. So you have to remember to either flush or have fluids running. So you want to give a little and you want to give it slowly. And remember, you don't want to slowly put it in there and then flush it all in quickly. That just means you gave a delayed medication. Now the most common reaction is hives, and a lot of people want to reach for Benadryl, but we really discourage this for several reasons. First, it can cause or worsen hypotension. It can also thicken mucus secretions, which can affect respiratory issues. And finally, and most importantly, it can hide what's happening for the rest of the reaction, because Benadryl is just symptomatically treating the hives, but it's not really solving the underlying problem. And so, for example, my colleague, whose kid has a peanut allergy, one time he happened to make a fruit smoothie and he added peanut powder in there. Unbeknownst to him, his wife was there in the kitchen and his kid came by and asked, "Oh, could I have some too?" And so the kid drank it and then developed hives. And so they gave Benadryl, the hives went away, they sent the kid to go watch TV for a while, and then the kid was acting kind of squirmy, not feeling so good, and then later developed audible wheezing, had to go and get epinephrine at an outpatient urgent care center. And so the lesson learned here is that when you get rid of the hives, you get rid of an indicator that can tell you what the direction these allergies going. Because most commonly, the hives are just going to go away on their own, with whether you treat it or not. But if they get increased in number or worsen, then this could be a sign that the reaction is progressing and it could turn into some sort of cardiopulmonary problem. When responding to a serious reaction, multiple tests need to be accomplished, most importantly, getting the correct medication dose. And rather than relying on faulty memory, we recommend posting treatment algorithms throughout your imaging department. For example, we post them within the imaging suites and outside of the scanners by the technologists. This can help reduce confusion. It's important to know where your medications are located, whether they're in Pyxis, crash carts, departmental contrast reaction kit boxes, or posted by the wall near the scanner. In summary, if a patient's having a vasovagal reaction, remember they're hypotensive but bradycardic, you want to elevate their legs, Give them oxygen by face mask, 6 to 10 liters per minute. Give them IV fluids wide open, and then atropine, 0.6 milligram to 1 milligram if they're still symptomatic. Now, if they're anaphylaxis, they're hypotensive but tachycardic, you again want to elevate their legs, give them oxygen by face mask, IV fluids, normal saline wide open, and then epinephrine. If they're having bronchospasm, remember that's expiratory wheezing. You're going to give oxygen by face mask, 6 to 10 liters per minute, a beta-2 agonist inhaler, 2 puffs, can repeat, and then epinephrine if they're unresponsive to the inhaler. If they're having airway edema or inspiratory stridor, you're again going to give oxygen by face mask and epinephrine. And when you're giving epinephrine, remember you're going to give either 0.3 milligrams or 0.3 milliliters of the 1 milligram in 1 milliliter intramuscularly, or if you have an auto-injector, you're going to give it in the lateral thigh, or you're going to give 0.1 milligram or 1 milliliter of the 1 milligram in 10 milliliter intravenously with a slow flush or IV fluids running. Whenever you're going to give epinephrine, don't forget to call a code or 911. Thank you for your attention, and I look forward to seeing you at the RSNA Hands-On Simulation course. The following slides, I'd also like to acknowledge my fellow faculty organizers and facilitators as listed, including their pictures.